So let's go ahead and start today's lectures. I would like to introduce Dr. Ben Christiansen. He's a doctor of psychologist, and he's going to give us a talk on cognitive behavioral therapy by primary care physicians. And I'd like to say thank you to the Turner Clinic for sponsoring Dr. Christiansen's lecture.
Awesome. It's great to be with all of you this morning. So when they asked me to do this topic, I gotta be honest, this is an interesting topic to try to teach. First of all, I'm a clinical neuropsychologist, so I don't do a lot of cognitive behavioral therapy on a regular basis, but I have been trained in it. The big middle green button, right? There we go. Have no disclosures. As psychologists, we always get to share with people we make no money. These are all my professional affiliations, so I'm blessed in the fact that I have the opportunity to work with most of you through some way, and the fact that I have rights at all the main hospitals in the area. So if I can ever be of help from you, being a medical neuropsychologist, I play with the brain all day long. I love this one. I think this is perfect. This is kind of how cognitive behavioral therapy should be. The reality is, as professionals, oftentimes we forget the empathy part of mental health. And so when I saw this, a friend sent it to me a couple of years ago. I actually have this in my office to try to remind myself that it's very easy, even in my profession, to sometimes forget what the patient is going through. So let's cover the numbers just a little bit, because I think this is why it's so important in primary care. So we know that 25% of all primary care visits yearly are for mental health related issues. We also know that roughly mental health issues are twice more likely to see their primary care physicians than any other patient population. So I may go in to see my doctor for a sore throat once in a while, but if I have depression or anxiety or PTSD or some other mental health related issue, the likelihood is I'm going to see you twice as more often throughout the year than your standard patient's going to. And then research shows, and this is something that I constantly try to share with doctors, is that medication does not fix mental health issues. And that's an important thing to understand. The way I kind of explain it to patients is, if you are diagnosed with diabetes, we give you insulin, we give you medication for it. But if you go home and you eat Snickers all day long and you don't exercise at all, there is not enough insulin to save your toes. And that's the reality with mental health. You can give medications, and medications are good, but medications are only as effective as the other treatments that you provide patients, that you get them involved in. So I'll get phone calls on a regular basis from professionals going, I've given Prozac, I've given Wellbutrin, we've tried this, we've tried that, they're not getting better. And the very first thing I usually ask is, well, did you refer them for mental health counseling? Well, I told them they should think about it. Well, so you didn't ask them if they went, you just keep prescribing medications. How does that work? Because the research shows that the best way to address mental health issues is actually through therapy. But the easiest way to do it is with therapy and medication combined, because therapy and addressing some of those underlying mental health issues are actually pretty difficult, pretty painful. So we really use the medication to take the edge off, to stop some of that mental health spinning, if you would. Research even shows us that schizophrenia and bipolar disorder, which we know are neurochemical in nature, that if they're not in therapy, if they are not participating in life-changing behaviors, they will continue to return to the hospital for treatment because their medication will not be sufficient to regulate some of those issues. So let's talk a little bit about what's unique about Utah. So I loved finding this in 2014, but we knew this when I went to grad school over a decade ago. Utah, ironically, has a higher level of mental health issues reported than almost anywhere else in the United States. And we're seeing a huge growth. So this was done by KSL, and I laugh because it's partially correct. And what I mean by that is the depression prevalence is correct with us seeing a higher level of depression in the state of Utah. There's a lot of reasons why and a lot of questions and a lot of theories. But the prevalence by age and gender actually is not correct. That's correct based off of what the numbers we have from primary care providers. But here's the dilemma in human behavior. While the data isn't accurate, the problem has to do with the difference between men and women. See, women, when they have emotional issues, they go see their doctor. When men have emotional issues, they drink. And it's been shown over and over and over and over again that men usually choose very destructive behaviors. Well, one of the dilemmas that we have in the state of Utah is that we have a very strong religious culture that's anti-drinking. And so a lot of men just don't do anything when they're depressed. They still won't go to their doctor. They just don't do some of the things that usually get them in trouble that put them at their doctor's office. So what we're finding out in the state of Utah is that a lot of men just don't tell anyone that they're depressed or that they're anxious. They just don't do anything. So the numbers that we're actually seeing, there's a suggestion right now in the research that our numbers in Utah might actually be a lot higher than we even realize when it comes to mental health, especially among males. So let's talk a little bit about cognitive behavioral therapy because that's what I've been asked to talk about. Like it says, to really be trained in cognitive behavioral therapy is a lengthy process. It's about 12 years. So I want to take 12 years of your time today and try to teach you this. So I'm just going to teach you some very basic principles, okay? The key to cognitive behavioral therapy is located down below. How people think in specific situations affects how they feel emotionally and physically, and then it impacts how they behave. And based off of how they behave, it immediately impacts how they think, which then directs how they feel and what they physically do, which continues that cycle. So it's a cyclical issue that they go through. It's how they feel, it's how they think, it's what they do. This is another way to look at it. I love this picture. I share this all the time with patients when we diagnose mental health issues in them, when they come in. The goal is to break that chain, and that can be really hard. And the reality, like I said, is there isn't a medication that does that. This is therapy. This is addressing some of those core issues. So here's some ways to use it clinically for you guys. We can identify and then evaluate reactions to specific situations. We know that there's certain medical conditions that have a higher propensity for causing depression. One of the ones that I do a lot lately is traumatic brain injuries. So I spend a good portion of my day working with traumatic brain injuries. Research shows us that people with traumatic brain injuries, the 86% of people that don't get better, it's because they have an underlying emotional issue. But what I find very often is most of us never ask patients if they have a history of mental health issues. We assume we already know, or we would have asked them at some time, they would have brought it up. So if we know that's going on and that's going to spin, think about the symptoms that someone experiences from a traumatic brain injury. And they immediately go, well, I have headaches, that's from my head injury. Oh, my neck hurts, that must be from my head injury. Oh, I don't feel good, that must be from my head injury. Well, it might be. It likely isn't, because that's not really how head injuries work. But once they get into that cycle and start thinking, they start changing how they behave, and it just keeps filling in the difference until they wind up in therapy or they wind up in my office 12 months later because primary care providers have run out of ideas on how to treat them correctly. We identify and change that unhelpful thought. That's really the key there. Not just to change the behavior, but to help them address what's the thinking behind it. Is it a realistic thinking? And then by changing those, we can kind of help them reduce kind of that emotional piece. So the big key here is the thought process, not the behavior. Yeah, we want to discuss behaviors that patients might be doing, but we're interested in their thoughts. And one of the things I often share with doctors is it doesn't have to be a rational thought. Usually it's not a rational thought, but it might be based in some reality. And thanks to the master educator Google, everyone knows what they have before they walk in. I actually was joking around with a friend because I got online and started filling out some stuff, and I apparently have ovarian cancer. So I was grateful for Google because I'm getting an appointment next week to get that addressed, right? But that's the issue. That's where patients go usually for their information. And so instead of arguing with them about that, we try to educate them. So here's what some of the research shows us with our health populations. So for coronary heart disease, we've shown some moderate benefits from just doing psychological interventions. Why do we know that? Because we know that about 80% of people that suffer a major heart attack that survive, that within 1 year, they actually return back to the exact same behavior that led to their heart attack. What we have found in psychology is that the fear of death doesn't change behavior. So psychological interventions may be that answer to get better medical compliance, to get people to actually change the way they think, the things they do. We found that in COPD, cognitive behavioral therapy can be super beneficial. Diabetes, we see a significant uptake in individuals with diabetes and depression. We see that by improving that cognitive behavioral approach, that thought process, we can get their glycemic index under control. Oftentimes we can help them lose weight, especially in our type 2 diabetics. We can get them down to just some of that cognitive behavioral therapy can actually help them change their lifestyle in a way that perhaps they don't need their medication as often. Chronic pain, because none of us in the state of Utah are dealing with an opioid crisis right now. And the reality is methadone doesn't fix it. But cognitive behavioral therapy, we have found, has got huge benefits in helping individuals learn to regulate and think through that piece. Irritable bowel syndrome, chronic fatigue syndrome, some of these things, some of these weird kind of ones. One of my favorite ones that my partner works with, fibromyalgia, the we have no medicine for disorder. Getting them in and helping them work through that. Sometimes it's just helping the patient learn to think about it different. How are you going to deal with it? And then there's a whole slew of other ones, especially medical compliance. Anyone here ever have a patient through your entire practice that did everything you've ever asked them to do? Has anyone never dealt with medical compliance issues? Right? And we get frustrated with them. We're like, what do I got to do to get you to understand? Oftentimes, it's because of that thought process in them. I don't know what to do, so I just keep doing the same thing over and over, expecting a different result. And so they make not only themselves insane, they make us insane as practitioners also. But if we can put someone in there to kind of knock them out of that rut to do some cognitive behavioral therapy, you can see a major change in that. So here's how this is why it's important for us as doctors, because it's easy to say, not my problem, I'm going to medicate you, I'm going to refer you out. And yes, that is a great thing to do. It's great to get them into therapy. The problem is, we know they're still going to come see us as providers. So we can either be reactive, which is always a fun experience, or we can be proactive. So obviously, we can prescribe something to help them. We can refer them out. But we can also help them identify that maybe what they've just experienced, what they're going through, actually did impact them in a way they're not aware of. I sit there all day long, I get to diagnose people. That's what I do professionally. I diagnose neurological conditions. I've yet to ever have someone thank me for telling them they have dementia. I've never had a parent thank me for telling them that their child has autism. But it's funny because they'll come back to me and say, no one ever sent me to get mental health counseling. No one ever thought that that might actually impact the way I think or feel. That's kind of an important piece. If you look at a biopsychosocial aspect of how we exist as human beings, I think that's the piece in medicine that we often forget. We're so busy trying to fix the life that we forget to fix the person sometimes. So here's an example. And yes, I do dress like this at work on a regular basis. So this is actually an example of someone that we worked with recently. So we had this 35-year-old male come in that has just been diagnosed with type 2 diabetes, and his primary care physician sent them to my clinic right before I actually brought on a partner that specializes in this, and they said, we don't know what else to do. We cannot get his diabetes under control. We're worried there's some neurological stuff going on. So I sat down and I asked him about his type 2 diabetes, and this is what he said. It's just hard. I had to give up my entire life. I missed the things that made me happy. Have you ever asked a patient about that? Anyone? When you give them a diagnosis? I think sometimes, unbeknownst to us, we think that they should just be grateful that we found out what was wrong with them and that we can just prescribe something. But I think sometimes we forget to ask them, tell me how that makes you feel or what's going through your mind right now hearing that from me. And so in clinic, what we did is we worked with him, and it's a very easy thing that any professional can do. Instead of letting him focus on the, I can't live the life I want, I can't be happy anymore, we simply just got him to start talking, let's think of ways on how you can be happy. How can I do that? Okay, you've been diagnosed with this. How can we address your concerns? And that's the very simplest, easiest thing as doctors that you can do for a patient. You don't have to be their therapist. You can refer them to therapy. But if you can get them to start thinking about how can we address this, how can we change that thought process that, for example, your life is over, you will actually get them to comply so much easier with the things you need them to, because they'll actually feel like you care, like you hear, that like you're listening. That simple phrase, how can you change it, covers everything. It illustrates that you're actually in it with them, that you actually care, that you're going to help them figure out how to still live the life they want, but in a more productive way. And it suggests that there's a possibility and belief that changing does not equate to giving up one's happiness. Your life is not over just because you were diagnosed with diabetes. Your life is not over because I think you have multiple sclerosis. Your life has changed, but that doesn't mean you can't live a productive life. Let's talk about how we can do that. I'm trying to be really good because last time I spoke, we went over by like 20 minutes and they chased me off with a stick or something. The other thing I always share with everyone is the important one. There isn't one recommendation to rule them all. That's the reality here. Our goal as providers isn't to have all the answers, it's to send them for the best answers. But in the same aspect, to realize I can show empathy, I can help them understand, I get this is hard. Let's work through this together. Let's get you to someone. Because really our options are we can work with them and we can empathize with them and we can help them with an extra 2-minute visit, or they can come visit us over and 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 over, because that's what they do. That's what patients do, because they're looking at us to have that answer, to provide that. And sometimes we have to do that because I'm a psychologist. I refer people out all the time, and I can't find enough therapists. That's just the reality of the situation we're in Utah right now. We have some insurance companies that just do not have enough therapists to take that insurance. But we got to do something with the patient. So if we can even start helping them think a different way about their medical condition, we can help them at least alleviate some of those symptoms until we can get them referred to the right person. Any questions? Please. That's great. So so she was asking about living in a rural community and not maybe being able to find someone that's competent. The interesting part is that almost every therapist has to be trained in cognitive behavioral therapy. It's one of the requirements. What I often find that I teach young therapists about, and I even teach patients, is that what usually happens is they go, my doctor sent me to therapy. Well, what are you here for? I don't know. Okay. Well, tell me what's going on. I'm sad. Well, that's like showing up to your mechanic and saying, my car doesn't work, here's a blank check. and then not understanding how your little Pinto turned into a Lamborghini cost-wise, right? And so what I share with people and what we often do is, first of all, I try to meet with all the therapists, but then I have a discussion with them of what I'm expecting, but I teach patients, this is what you need to go in and tell them. Even if I have to write it down on the referral for them, I need you to work with them on dealing with the fact I just diagnosed them with this. If you want to talk about mom not giving them a lollipop when they were 2, great, you can do that afterwards. Right now, I need them to get compliant on their medication. I need you to help them with that piece. We can worry about other stuff because therapists have a tendency to be voyeurs. I was just sharing it over at the table. I'm that guy that actually shows up at the airport 2 hours early because I like to watch people. It's what I do professionally. I'm maybe a freak, I don't know. I'll let the people that I work with decide why I'm in the basement, really. But the reality is, I think it's oftentimes us just directing the therapist, here's specifically what I need you to work on, or telling the patient, here's specifically what you need to talk to the therapist about. That usually resolves it. What I mostly hear, and sometimes there is that financial piece, the bigger part is patients don't want to go to therapists because therapists want to keep them there for the rest of their life doing therapy. And most mental health related stuff associated with medicine is really short-term based therapy. In our clinic, it's usually 6 to 8 minutes, or 6 to 8 weeks. That's about the extent of what we have to do to really get them turned around. Other stuff, we refer them out to other things.
So when I come to lectures, I hear about cognitive behavioral therapy. When I read literature, I hear about that. When I send my patients to therapists, they get EMDR. Can you comment maybe on that technique and if that's something that's going to be valid for my patients or not?
Perfect. So EMDR is an eye movement desensitization program that has come out recently using for post-traumatic stress disorder. One of the dilemmas we often see is that when everyone sees the new toy, everyone thinks they can apply it to anything in the world. And the reality is they shouldn't be using that. It's not a great technique to use, but I think one of those dilemmas that we often see is, are we actually assigning it? Are we telling the therapist, here's specifically what we need you to address? My patients coming in, they've been diagnosed with MS. Yeah, that's traumatic. That is not PTSD. PTSD is the extension of a traumatic experience that continues to elicit behaviors over a significant amount of time for no reason. That's not me diagnosing you with a medical condition. And I think sometimes we like to mix those two up. And so what I often find is if we turn and say, I need you to do cognitive behavioral therapy. I tell parents all the time when I diagnose their children, what your child needs is behavioral modification. Your 5-year-old is not going to sit down and talk emotions with an adult. They don't have the vernacular to do it. And so it's about giving specific recommendations. And so what I share with my providers is write down specifically what you want addressed. I want you to do cognitive behavioral therapy addressing this issue. That's why I'm referring them to you. And what we're blessed in this area for is if they won't comply, there are other people to refer to. It might take me a while to find them, but we have therapists show up at Tanner Clinic all the time begging for us to refer to them. And I make it very clear, if you're not going to do what we've asked you to do, I'm not referring to you because I'm not seeing the patient for you to go buy a second home somewhere. Please.
We have time for just one more question.
Perfect.
So, is this on? No.
I can hear you.
Okay. So I used to live in a really rural area where everyone grew up with the therapist now, and no one wanted to go to them. So I was wondering if you could comment on phone therapy and remote visits and counseling.
So like telemedicine type stuff. So phone therapy, telemedicine. So while I know that medicine as a whole is moving that way, in psychology, we've been doing it for years. We've been doing telemedicine for years, and actually the research shows that the difference in quality and perception, the difference is about 1.5% measured. So the reality is, from what we hear from patients and outcomes, there's almost no difference whatsoever in what we're seeing using telemedicine or other forms. And that's one of the nice things. And what we're also lucky about is insurances have been really, really good with mental health. opening that avenue for us. While they're a little slower for medicine, they're moving very, very quickly, and they've moved very, very quickly for mental health. And I think because there's a pretty significant crisis with mental health. We know that if someone with severe depression doesn't get treated, there's a likelihood of a hospitalization or a suicide attempt. And so they're more prone to have to move with great haste. So we're able to use that, and we have amazing outcomes with that. Awesome. Thank you very much.
I'd like to thank Dr. Christiansen for that lecture. I certainly believe it would help me improve my patient practice.